Emergency Department for two reasons for choosing this beautiful topic of pain, which is surplus around us. Surplus is something which we always never remember to look into. So looking it into in the concept of pain is pretty good for the chaplaincy. And second, I'm deeply delighted that they have got a title which is so simple on pain, not choosing a title like the contemporary confabulations on the perspectives of pain associated with its own confabulation would be by itself a pain. So I think a symposium just on pain is beautiful, and it's a meaningful exercise. Thank you, sir. It's wonderful listening to the first session. I'm sure there are a lot of Judeo-Christian questions which will come in the plenary and group discussions, I suppose. And way back, I had a phone call from one of my students from Singapore. She said, I just remembered you, so I called you. I said, what happened? You remember me? And she said, I had a pain in the neck, I just remembered you. So I was taken aback. Why did you have a pain in the neck and you remember me for that? Actually, what she meant was she wanted me to have a word of prayer for her pain in the neck. But the way she put it was, I had a pain in the neck and I remembered you. So it could be in either way looking at the pain perspective. Several years back when I had a severe headache in the morning, I work in the emergency department, and I had a headache in the morning. So that was not a good sign. So I walked in to check my BP to find it was shooting pretty high. And that was the part when I was started to be treated for hypertension. And then when I titled my own pain as Healing Through Pain. Had I not the pain, I would have missed out seeing the hypertension within me. Well, that's besides the point. I'm delighted we have an expert speaker with us, Dr. Tharion, with us this session. And he is renowned within CMC. We all know him quite well for the benefit of a lot of us who have come from different parts of the country. I would share a little more about him. He's a professor in the Department of Physical Medicine and Rehabilitation, an alumni of Trivandrum Medical College in the UG, and also his diploma in ortho and diploma in rehabilitation, and also subsequently with MD in rehab medicine. And he has been internationally exponent. He has done his senior training fellowship and also special training as a UK, Australia, and also at USA. To his credit, he has more than 50 publications at international journals, had guided more than 19 students on their MD perspective, and had been involved in the spine injuries as a predominant field of his expertise. And of course, apart from all these academic laurels, he had been the former deputy medical superintendent of CMC, former head of PMR of CMC, and there are lots of laurels that I am sure it will be nice if his wife is also around to listen to. Why I'm saying this on a lighter note is a very good sense of humor. And also, if you have doubts which are not cleared, every morning you can meet him on his run, which is going around the campus, which he never stops, and a very ferocious is not a right word, voracious reader, and has his own interest in the field of reading. But with adding all to that, I'm sure this morning he'll enlighten us on the very concept of sensation and sensitization of pain. Over to you, sir.
Thank you, Dr. Ravi, for that kind word of introduction. And also let me thank the chaplaincy, especially Dr. Aruldas, for inviting me for this talk and giving me an opportunity to talk on this topic of pain and to share a few facts about pain and also some interesting turns and twists and some observations about pain. So pain and pleasure are the main driving forces of the human behavior. Avoidance of pain and pursuit of pleasure are the dominant motivational forces that draw us in different directions. It's a constant pull and push. One through a positive reinforcement and other through a negative reminder. Pain signals, along with other sensations like touch, from the nerve endings of the skin, it reaches the brain through the spinal cord and report to specific locations on the brain. The information regarding pain goes up to the brain as a three-tier information system through a first cell, and then from there up to the spinal cord, and the second to the base of the brain, and then from there to the cortex itself. Almost like the first call, second call, and third call to inform the brain regarding the painful source. So these signals act like a signaling system. Incidentally, even though the brain is responsible for recognizing pain from every millimeter of the body, every part of the body, paradoxically, brain itself cannot sense pain. You can cut the brain with a knife without eliciting any pain. This principle is widely used in neurosurgery, which is known as the awake surgery. Interestingly, each part of the brain reports to the specific adjacent locations in the brain. That's one part of the from the tongue to from the lips or the mouth and the fingers and the hands and the legs are all located in adjacent parts of the brain. So the whole body, it appears as though the whole body, there is a miniature man represented in the brain. This is popularly known as the little man, the homunculus, like a finger, small finger-like representation of the whole body of the brain in the brain is represented there. So this homunculus concept was discovered by a very famous neurosurgeon called Wilder Penfield from USA, Canada. And it was he who inaugurated our neurosurgery ward. And I think many of you who are walking through our corridors would have noticed this plaque in front of the N1 ward. The pain signals, some pain signals travel very fast along the thicker nerves to alert the brain very quickly about the potential harm and for a quick response to move away from the source of danger or harm. This quick pain is followed by a slower pain which travels slowly. It lingers longer. It invites attention to any problem that need to be interrogated, attended to, investigated, or addressed. So thus pain is our protective guard. One of the horrific cases that I remember in my mind is about a child who did not have pain. He was born with the insensitivity to pain. So I think such talks are coming later, but this case is still in my mind about a 4-year-old boy his mother was making vada for the son because he liked to eat vada. As the oil was boiling and the vada was also getting cooked in the hot rolling oil, this child put both hands into this boiling oil to take the vada and burnt both hands, but no pain. The child did not worry at all. The whole hand was burnt and eventually lost the hands, and but the protective effect of pain, when it was not there, the horrific consequences that the child had is shocking. Because these children also do not have sometimes sweating, the parents lovingly they moved to a cooler place of Tamil Nadu itself, and later on, years later, child is no more now because of the various other complications that has happened on account of the insensitivity to pain. These signals that get into the brain become pain in the brain. This pain perception can be thus seen as in two dimensions. One is our sensory signaling to alert the brain regarding the location of the painful source. So as you see in this slide, every part is located, every part is represented, maybe elbow, arm, face, nose, eyes, like that. So from wherever the sensation, the painful source comes, it is immediately localized in the brain. So it helps the person to understand and localize the question, the crucial question: where does it hurt? This is the common question every doctor will ask, every person will ask. I have been in pain. Okay, where does it hurt? So this is the crucial question for localization as well as for diagnosis. And the nature of the source of pain. Is it a pin? Is it a thorn? Is it a knife? Is it burning? And so on. So the patient describes these somatic or the body signals. The words commonly used are pricking, burning, crushing. So those are the words that you use for this sort of signals. Now we come to another dimension. So this dimension comes to the affective dimension of the pain. The effects, how it affects, affective dimension. It is conveyed from this area of the brain, this part of the brain, through its additional connections or projections to the several other parts of the brain. Like, we'll say, the area which is alerts the entire brain, something called reticular activating system, a network of system which activates the entire brain. So that when the pain comes through that area in the back of the brain, the entire brain is activated. As the previous speaker said, the St. Paul said, when one part of the body suffers, the entire body suffers. The reticular activating system, the entire body is affected. Then the other areas called, for example, the area which deals with fear, they're called amygdala. So the fear is always required to protect yourself. So you know, once you burn your finger, you know that this is hot, therefore that fear has to be there to protect you. Then the areas that deals with emotions, what sort of emotions it elicits, this is known as a cingulate cortex, like that. And there are some areas that deals with the autonomic or automatic responses, like the heart rate, the sweating, which is not in our control, like insular cortex that deals with that. And there is also an interesting area in the middle part of the brain, mid part of the brain, or periaqueductal area, and always say like that, that part which is capable of stopping the pain. That's another paradox. It can stop the pain. And ultimately, the area of the thinking cortex, the cortex in the front, which deals with the thinking and how it can modify the pain. So these complex connections, now these pain signals has now made connections to the area of the emotion, the fear, the automatic area, the thinking cortex, and then ultimately how it affects the brain, the affective component, and it helps to answer the question, how much it hurts. So when the pain perception thus now become intertwined with mood, attention, fear, your cognitive states, and acquires this affective domain, and the patient now describes this unpleasant sensation. That is why sensation have now become unpleasant. This is why the electrical signals have now acquired another dimension of getting it to become unpleasant, because it has now interacted and negotiated with other areas, and now the words they use are different. If they're saying pain is agonizing, distressing, exasperating, so the words have now changed. Vocabulary has now changed. These are the words they use when the affective domain has come in. The same painful signals has now gone into other dimension. So the prolonged states of pain, this we don't know when the pain is going to come. Those sort of pain may produce a lot of anxiety, the anticipatory anxiety, and constant anxiety can also lead to depressions of mind. Now, going to another factor of this tolerance of pain. You know, some people tolerate pain better, others don't. The spectrum of pain tolerance varies in different people, and also different situations, and also in different states of mind. So it has been observed that those who are good at physically demanding professions and all that, they are more tolerant to pain than those who are more sedentary professionals. Another aspect I would like to talk about is the descending control of the pain. The descending control of the pain. That is the top-down control. In 1960s, there was a startling discovery. It was observed that stimulating some part of the brain, in the lower part of the brain called middle part of the brain or periaqueductal gray matter like that, it could block the pain sensation. So it is a lot of excitement. Oh, we have found out this place where we can block the pain. This led to the discovery of the descending control of pain from the brain to the peripheral areas. The input from this thinking cortex, the prefrontal areas or the emotional cortex, all converge to the brain stem, that is the periaqueductal brain stem, informing about the pain. This brain stem then sends signals down to the spinal cord to inhibit the pain that is going to ascend upwards. This is also revealed in situations of extreme stress, which is a common observation. We would have also gone through all this. For example, in highly competitive sports or combats or even war or even extremely aggressive situations or highly happy situations, the injury sustained during these extreme events is not noticed by the persons until the competition or the combat is over. It's a stress-induced analgesia. With injuries sustained, they continue to complete the acts. It is probably due to the pain-blocking chemicals which is made in the brainstem to block the pain. That was led to another discovery, which was another shocking or startling or interesting or puzzling discovery, that brain synthesizes small proteins called endorphins. And these endorphins are morphine-like substances. So that was always puzzling. Why is brain producing morphine-like substances? So it was now found that later on found that it is a substance that balances the pain, reduces the pain, blocking the pain. And these receptors for these endorphins are present all throughout the body, not only in the brain, in the peripheral tissues, in the muscles, skin, everywhere, to ease off the pain. And the most abundant in the brainstem, in the periaqueductal area, where it was found in 1960 that area is capable of blocking pain. So these observations paved the way for using mood elevators or antidepressants and many other drugs for the control of pain. The role of acupuncture is known for centuries for pain relief, even for surgical procedures, which can be explained by this internal pain control mechanism, even though the exact neural pathway has not been elucidated. In addition to the blocking of pain by the brain, there is another level of blocking as the nerve is entering into the spinal cord. The nerve is entering from the hand or somewhere into the spinal cord. There is a pain blocking mechanism. That mechanism is widely known, discovered again in 1965 by a person called Wall, W-A-L-L, and along with Melzack. He discovered that there is a gate control theory. There's a gate control theory of pain, based on which several other methods of treatment came in. So it is interesting that it is the scientist called Wall who discovered the gate. So these scientists found that there are nerve cells in between the spinal cord and the first cell and the second cell. I told about the first call and the second call, or the first cell and the second cell. There are some cells located there which is capable of blocking the upward transmission of pains. So the stimuli, small stimuli like normal painless stimuli like touch or pain or pressure, or even counter irritants like balm applied, or some electrical stimulation around the pain site, block the pain. The classical example is when we are small or when you run around and the child falls down and injures the knee and comes to the mother with tears. Mother puts the child on the lap, and then wherever the skin is damaged, around the skin, the mother will rub the skin, and immediately the tears are stopping and the pain has gone. Of course, there is emotional support as well as the fibers, the touch around the injury site. That is now sending electrical signals and blocking the pain, the big gate control theory of pain. Another interesting fact is about I would like to mention is about the phantom pain. The pain on the parts that does not exist. This is a strange observation that the patients who have underwent amputation, the amputation means cutting off remove the hand or leg for any reason. Patients come and say that the patients where the arm is not there, but I can still feel my hand is still in pain or the leg is in pain. So it was thought, how is it possible? So maybe they are depressed. Various thoughts were there. So here patients are perceiving pain on the part which is currently not there. So it is only recently that puzzle was unraveled with now the fMRI, functional MRI studies, and these sort of structural organizations that was found in the brain. This puzzle has now been unraveled. It is observed that the brain cells that are located adjacently, for example, in this area where the hand is amputated, the area located adjacent to that is the face or the shoulder. The nerve cells may there try to grow into the adjacent areas. Thereby, when you scratch your face or the toothache comes or some other comes, you will feel as though the hand is in pain or difficulty in distress. So based on this, so that is some remapping has happened in the brain. The part that is grown, amputated hand, leg, does not receive it. Those cells are not receiving any signals on the brain, on the foot, on the leg, from the leg, because the leg is no longer there. But the adjacent cells are now starting to grow into these areas. So remapping is one method has happened, and based on this observation, simple technique, very elegant, unique, simple, effective, elegant method has been used as a treatment called mirror therapy, using mirrors to cheat the brain, because the brain is being cheated, saying that the brain is cheating the person, saying that the leg is in pain, which the leg is not there. So you use a mirror to cheat the brain back, using some images using simple mirrors to remap the remapping that has happened. This was described by a celebrity neurologist from USA called Dr. Villayanur Ramachandran, V. Ramachandran, who was a great neurologist who graduated from Madras Medical College, and he became the founder of a series of studies. He has a book called Phantoms in the Brain, which is very widely read by all over the world. Another interesting fact about the pain I would say is about the referred pain. So the pain from the internal organs like heart or maybe gallbladder or maybe appendix also enter the spinal cord through these nerves, along with the nerves that convey pain from the neck or the arm or the shoulder and all that. So the brain gets confused. The brain gets confused because the signals are coming from the painful source, may be coming from the heart, is also traveling, the pain from the hand also is traveling along nearby. So sometimes the heart pain thus may be referred to the shoulder pain, or the gallbladder pain may be coming from, you may feel as though the pain is coming from the shoulder problem, because patient may say that I have got left shoulder pain, hand pain. So it may be a heralding of a heart attack also. So this, because all these fibers travel very closely. Now I would like to speak a few things about sensitization. Sensitization So I've spoken something about the senses of sensation of pain and how it all changes the experience of pain. Now, so sensitization. Sensitization is the amplification of the pain. Why should it be amplified? Because again, it is a protective device, a protective mechanism, it's a protective guard. And if it is not there, I told an extreme example of what happened to the child, but several other things can happen. One is, it can be, sensitization can be a structural level or at a behavioral level. This amplification is required because we don't want any pain to be ignored, whether it is from a shoe bite or is from any other major problem, everything has to be attended to. So the amplification can happen at the peripheral level. Peripheral level means at the hand also, due to some chemicals released as a part of the injury at the site of the wound. So increased pain draws attention to the wounded site and enables the person to take the remedial measures to limit the damage produced by that injury. And a central sensitization that happens in the brain and the spinal cord to increase the appreciation of pain and attention and response. Sometimes the central sensitization may linger and go on and on, even beyond the site of injury. And that can lead to situations like chronic intractable pain. The protective shield of pain now, the shield itself has now become a problem. Protective shield of pain has now gone out of control, and that has become a problem. That is a chronic pain and reflex sympathetic dystrophy, pseudox dystrophy. Lots of terminologies are there to describe the problem, but where the sensitization has gone out of control. So briefly, I would like to mention again about the behavioral sensitization of pain. How can this chronic pain, chronic or acute pain, modify your behavior, your outlook? One is the vulnerability. The person in pain recognizes his vulnerability when he is in pain. In the absence of pain, pleasure is accessed or purchased at will with little regard to the possibility of ever being in pain. No one wishes to be in a vulnerable state. So pain takes you through a realm of vulnerability where you seek someone else's help, to reach out to others for assistance. And it is a state when you recognize the need for others, for support, comfort, and relief from pain. Second is the compassion. A state of pain can also make you compassionate to our companion. It will be easier for a person in pain to be empathetic, to recognize, to sympathize with a fellow sufferer. For example, a person with a particular condition like migraine, with a severe headache, will be able to understand the suffering of another person with headache. The suffering of pain thus produces a paradigm shift in the process of thinking of the individual. A change from the daily routine and daily tasks. Outsmarting our comrade no longer becomes important. Instead, your competitor is now your companion. Prioritizations. That's the third one, I thought. Pain helps a person to reset priorities in life. All positions, titles all become immaterial. So pain provides and offers an opportunity for a person to be aware about his surroundings, to pause and reflect and change decisions of life. History is full of events and stories of people who have taken path-breaking decisions when they had to personally encounter severe pain, physical pain, emotional pain, or whatever that hurts. Lastly, searching for the Almighty. During pain, one seeks out for powers greater than oneself. When all is well with no pain, one may consider oneself to be at the center of the universe. But in trying painful conditions, one looks for greater powers, higher powers, to take refuge and realize God to be at the center of one's life, thus attaining a new meaning in the journey of life. So, pain, though a sensation, through its sensitization, by sensitizing abilities, through its sensitization of the person, through connections with this emotion, fear, and thinking parts of the brain, helps us to recalibrate our mind and could potentially help a person to move forward for the better, hopefully. Thank you.
Thank you, sir, for taking us into this amazing world of neurophysiology. And I think sir has really taken us into this world in a very simple terms so that we could best comprehend the complicated world of the brain. That I think there was one beautiful definition. The very purpose of human body is to carry the brain around. So that was an interesting way they had put why the function of a human body is all about. But I think I'll keep the floor open now for your reflections or questions or any clarification that need be. We have 10 minutes to go for it. And so you can raise your hand and verbalize so that sir will certainly add on to what he needs to share. I'm very sure your neurophysiology is working now to how to coin the questions or
Dr. George, how does the body adapt to pain? When there's recurrent painful stimuli, how does the body adapt to pain? What is the tolerance mechanism to pain?
I think adapting of the pain may be again through the peripheral as well as the central mechanisms. Peripheral as well as the central mechanisms. And usually the sensitization is only augmenting pain, increasing the pain. Sensitization mechanism is to increase the pain, awareness has to be increased. Adapting must be through the other rest of the cortices. Though I said about the pain thing, the endorphins mechanism, and also all the popularly known as the happy hormones, the dopamine, the oxytocin, the endorphins, all are hormones, or all are chemicals that increase the pleasure part of the brain also. So how do you increase your endorphins? And endorphin is increased mostly through One is, easiest way is lot of exercises. Second is through even food or chocolates or happy conversations or jokes or laughter. All these are mechanisms where which elevates the pleasure state of the mind. So these are the things that we can do for adapting the mind. Left to itself, the brain may negotiate for itself, the thinking cortex may negotiate itself that you have to probably accept the pain. If that is the way the person is going to take, we do not know. That is why the healing persons or even I know the chaplaincy and all always visits the people who are in pain. What does that visits do? Of course, it's the personal contact, the touch, the talk, the comfort, the jokes that you say, or the books that you give, or the song that you sing, or all these things. All these stimuli will increase the endorphins and the other happy hormones of the brain to adapt the brain. So every effort, every step, every small thing, every smile, or whatever you do has got great impact. That is why I think Mother Teresa's famous quote saying that there are no great acts. There are only small acts with great love. So the previous speaker had spoken about the pain and the love, how both are diverse situations actually. One is painful, you want to run away from it. One is love, you want to go towards it. So how those things couple together. So the chronic pain, where each person, how it will go, we do not know. If you are in a constantly situation where the pain is constantly going to affect you and there is no relief, there is no remedy, and there is no companionship, there is no way out, maybe he will get into depression and all that. But the brain always, our ability to survive and ability to overcome is enormous. The life survives because of that, because we will be able to find our own humor, our own method of pain relief through physical methods as well as through social and other psychological methods. I hope I answered the question at least partly. Thank you. Both structural basis as well as the social basis.
Excuse me, sir. One more question. Sorry. Yeah. Sir, are there any physiological changes in the pain, the way it reacts to the mental issues and also physical issues?
Oh, yes. I think Dr. K. Sekar will be speaking on the chronic pain and the effect of the pain on the body. That's what I mentioned about that later. His talk is coming. Structural changes happen. Structural pain changes. That is all with all the MRI and all those things that was found was that brain changes that you would have seen. The problem with, for example, let us now take the corollary part of it. That is a constant seeking of pleasure and addictions. It changes the brain. Pathways changes. If you look at the behavior, what is behavior? Behavior, if you look at come to the cellular level, lowest level, if you say what is behavior is synaptic reinforcement. Synapse means one cell of the body communicates to the next cell. So if you keep on giving a stimulus to the next stimulus in particular way, that gets reinforced. That's the basis of learning and memory also. So the long-term potentiation and always say like that. So that reinforcement happens by that behavior. Constant pain. Also, it takes away various other dimensions of your activity because the body is constantly engaged in nursing whatever the pain is there. He's not engaging in the social activities, other pleasurable activities, other ways in which he would have done had there not been this painful focus. So the reinforcement of one pathway alone, it retards the activities of the brain. Structural changes will happen. That's a known fact also. Thank you. Structural changes, of course, leads to the physiological changes. That's the question.
Well, I think if there are not much questions, let's conclude. And it's very interesting look at the neurophysiological perspective. And there's a big topic which will open up a Pandora's box called the neurophysiology of theology. I don't know if people have looked into that particular aspect. There are several published articles and research literature which speaks about the dopamine. They have done studies on the dopamine level of individuals who are fanatic, who are radical, and atheist. Now, don't ask me what are the findings to check your dopamine to become religious by increasing your dopamine or becoming fanatic, but there is an undercurrent of connection between all these elements in the way we think. And there's another field called PNI, that is psychoneuroimmunology, by which your perspectives do change by virtue of your deep thoughts that do take in. And for me personally, to add to what Sir said, I have been in the field of emergency for 24 years, and I found this very concept of pain in that department is very challenging. There are times I felt, oh, enough is enough, let me quit and move. Because we see death every day, literally death every day. So at some point, you become like, I'm still keeping right in front of the take-home message of the behavioral sensitization. I tell my staff, if you don't feel the pain of the patient to an extent, you take a break, you take leave, or change the department. Now, you can't be sensitive to pain in emergency so much that it will affect your thinking so that you need to make decisions for care of the patient. But at the same time, you can't move yourself out of the painful scenario and say that now I am detached so that I can think clearly. So it is very challenging to work in such an environment where there is a repetitive exposures of pain which can insensitize or desensitize your very understanding of pain. So that is why a concentration is good that we are starting day one, session 2 on the physiology of our thinking, which is very important when we look at even spiritually. I trust with that note, take home message of the behavioral of the 4 components and much more components that you may have. And we hope and pray the forthcoming exercises of our understanding of pain and performing will be to the extent that will reach out to the people who need it. And so with that note, let me thank Sir for really putting it very simple across so that we can still take it back and rethink the way we think towards pain management. So thank you very much, Sir. Let's give a round of applause for him. And I think a time for memento and all that.
Once again, on behalf of the floor, we want to thank Dr. Tharion and Professor T.S. Ravikumar for being with us. And on behalf of us, we would like to honor you, sir. May I request Mr. Samuel David, sir, to please come in the front and honor Dr. Tharion with a small token of love. Mr. Samuel David, sir, is head of staff training department. And to the moderator of the session, to Professor T.S. Ravikumar. Thank you, sir. Thank you so much. I have a few announcements before we go for break. The first thing is what are topics being discussed throughout this pain symposium or symposium on pain. We are aiming for a publication. So still, the slot is open. If through the sessions, definitely you can reflect on some of the themes. So feel free to mail us or contact us, but we would like to have your abstract as soon as possible. So the essays are invited for this, especially for this publication. And the second thing is we request all our friends, those who could not register in the morning, to please do the registration during break. And we are very much sure that you have this ID card, and behind the ID card, there should be a group number. Okay, if at all, if group number is missing, may request you to please consult the registration desk. You'll be given a group number. Thank you so much. Now we'll go for break and we'll come back at 11:20. Thank you so much.